Okay. Woo. Connected. Yay. All right. Hey guys, I am getting things ready here. For those of you watching the replay, if you don't mind hitting hashtag replay or just putting replay in the comment section, I'd love to know who is watching the replay. And also if you have any questions in the replay, folks, I do go back over my shows to make sure I catch any of the questions and comments that I may have missed. And I see a lot of people jumping on board this evening. As you can see, my setup is just a little bit different this evening because I'm going to try to demonstrate an exercise tonight. So I had to kind of set this up a little differently so that y'all could see my feet when the time comes. So hopefully we'll get it right. Hey, Brett, how you doing? All right, guys. Don't be shy. Guys, help me with my mic check. Let me know if you can hear me. Hey, Susan, how are you? Welcome to the show again. Hey, Linda, good to see you. All right, guys, thank you so much for chiming in. Don't be shy. Let me know who you are, where you're from, and what is in your mug this evening. I'm with one of my new Cosi Talks beer glasses, and yes, I am drinking milk. I know, it's weird. Hey, Sandra, how are you? I'm also one of those weirdos that I put ice in my milk, and my husband thinks it's the weirdest thing ever. Good, you can hear me. Hey, Jody, getting ready to be your prof. Get your prof hat on. We've got Greg on board. Oh, thank you, Greg. Hey, David, glad you could make it this evening. Okay, good, you guys can hear me. Yay, I got my microphone right this time. All right, I'm going to give you guys a few more seconds to jump on board. And guys, feel free to tag folks. I'm not able to tag anybody from here, but if you know of anybody who was interested in watching the show, or if they had questions on the support groups, go ahead and tag them and see if they'd like to pop on board. You put ice in your milk too? All right, cheers, Debbie. And I've got cookies waiting for me for after the show is done. That's my little reward for today. Just your mug? Okay, Brett, you got your mug. And guys, I do have the Cosi Talks glasses and mugs for sale on my website, cositalks.com, so you can go and grab yourself one if you want to be one of the cool kids. Hey, Bonnie, how are you? All right, guys. So we've got a good show tonight. Like I said, tonight I'm going to try to demonstrate one of the exercises that I talk about a lot on the show. And actually one of my viewers sent in a question about this exercise. So hopefully I'll be able to clear that up tonight. Hey, Teresa, thank you so much for tagging her. I like that. Hey, Jeff, bobbing around the Chesapeake Bay looking for a place to anchor for the night. Jeff, that is a nice place to be in. Nice work. I hope you get some good blue crabs there. Thank you, Teresa, for tagging some folks on there. I appreciate that. All right, guys, I'm going to go ahead and get started. For those of you who are watching for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for over 18 years. And my passion is working with the limb loss community. So I'm going to put my milk down and we're going to get ready for this first question. So guys, those of you who have had a chance to visit my YouTube channel, I've been beefing it up this year by trying to put more videos, more examples of exercises and things like that, because I know that that's obviously what I'm here for. So, hey, Ashley, back to school tomorrow for teachers. I know my kids are going back next week. So these next few days for me are cuckoo crazy. I've got 4 kids and I'm getting into 2 new schools. So it'll be lots of fun. All right, guys, I just threw up there. Hey, there's my Mark. I was wondering where you were. Hey, Van Gregory. Is this the live show? Yes, this is the live show, Van Gregory. You are in the right place, my friend. Brian Bishop's got his double shot of Bustelo. Man, you are good to go, Brian. I need some of that into my ice milk. That's what I need right now, a little ice Bustelo. All right, guys. Hey, Carolyn. So, guys, I just posted a link to my YouTube channel to my tennis ball exercises, okay? And I'm going to explain a little bit about what that means. So when you're doing your strengthening, as you're recovering from your limb loss surgery, one of the biggest muscle groups that you need to really strengthen are the glutes, your butt, right? So the muscles in your behind, in your bahucus, in your patootie, however you want to call it, okay, those are the muscles that help stabilize your pelvis. Those are the muscles that help power your gait pattern. Okay. And I call it a lifelong process, honestly. Whether you have 1 leg, 2 legs, no legs, in order to get yourself moving and mobile and motoring, you need to have strong glutes and you got to work on it. So from day 1, guys, day 1, physical therapists work with their patients to help strengthen those gluteal muscles. Okay. Here's one of my favorite exercises to do. It's the tennis ball exercise. And as the name would entail, all you need is a tennis ball. That's it. Okay. Now, the purpose of this exercise is not only to strengthen the glutes, but it's also meant to help you get used to standing on your prosthesis. Okay. And the ability to put weight in your prosthesis early on in your recovery is huge. It's paramount in setting up the stage for the rest of your walking pattern. Okay. The sooner you're able to start weight bearing into that prosthesis, the sooner your brain starts to recognize that that prosthesis is a part of your body. Okay. And you guys have heard me talk about that a lot on this show. So I'm going to try to angle my camera. Bear with me for a minute, and I'm going to show you how to do this tennis ball exercise. Let's see how many things I drop in the process. Okay. All right, guys, ready? Can you guys still hear me? Can you guys give me a thumbs up that you can still hear me? Okay. All right, so as you guys can see, I have a chair. I don't know if you can see it, if it's kind of blending in, but I have a sturdy chair right here. So with my patients who are first starting out, I'll either have them use 2 chairs, one on each side, or holding on to 2 hands with the kitchen counter, okay? So for the sake of this demonstration, guys, we're going to pretend that I am a left amputee, a left-sided amputee. And it doesn't matter if you are above the knee or below the knee. You can perform this exercise the same way, okay? So my prosthetic side is going to stay planted on the ground. My sound limb is going to go on the tennis ball right here, okay? So you can see, and I'm putting it under the balls of my feet, okay? I know I have a really big shoe on right now, so let me just take my shoe off so you guys can see that better. So I'm going to put the tennis ball right around here, around the balls of my feet, okay? And basically, I'm holding onto the chair, and I'm tightening my gluteal muscles on the prosthetic side, which is this side right here. We're going to have to pretend for me, okay? And then you start by moving the foot forward and backward on the tennis ball, almost as if you're giving your foot a little tennis ball massage, right? So when you're first starting out, the ball's going to go skittering out every which way. In fact, the person who actually, Steve, emailed me this question, he said, how do I stop the tennis ball from squirting out from under me? And yes, those were the words that he used. So guys, it's all about the control, okay? So when you're first doing this exercise, you might only be able to do just tiny, tiny little movements to keep control of that ball under your foot, okay? And this is where the tightening of these muscles comes into play. If you're doing this and kind of just hanging on the ligaments of your hip, you're not going to have control, and that ball is going to go skittering out, okay? When you tighten those glutes, you see how my leg is nice and straight here, and then you do the small controlled movements, okay? And believe me, you do this for about 15, 30 seconds, you're going to start to feel some burning in your tushy right there, and that means that those muscles are working properly, okay? So first you do the forward and backward motion. Then you kick it up a notch, and you go side to side. And again, this is a bit more challenging, especially I'm actually starting to feel it right here now. When you go side to side, right, to keep control of the foot. And again, I'll have my patients do this for about 15 seconds or until they start feeling that burn in their tushy right there, okay? So once you do forward and backward and side to side, the next challenge is going in circles, okay? So you'll go in circles, and in this case, I'm actually going clockwise. And we'll do that 5 times. And as you can see, the ball is starting to migrate on me, so I need to get better control. And then after going clockwise, we're going to go counterclockwise. Okay? So guys, as you can see, it's a lot of control. It's a control here, and it's even control on this leg, okay, to keep these things going. Now, my particular viewer said that he was able to do this 30 times, which is really, really good. So that indicates to me that he is ready for the next size. This one, okay? And again, this ball is about the size of a basketball or a small soccer ball, guys, okay? So if you find that you can go forward and backward, side to side, circles, and do each of those for 30 seconds each, it's time to kick it up a notch. And this is how you can progress this exercise, guys. And again, this goes for my above the knee and my below the knee amputees, okay? So again, we're pretending that this leg, my left leg, is my amputated leg. We're gonna pretend that I'm standing on a prosthesis. You take the sound foot and same thing. You go forward and backward, side to side. You can see my cat there making an appearance. And then do circle exercises, okay? The better and the stronger you are, the bigger you can make the ball, okay? All right, guys, let me see if I can put this thing back together again and get this stage back. All right. Were you guys able to see that okay? I know I wasn't able to read the comments while I was doing that exercise, so I'm going to put my set back together again if you give me a moment. All right, let's bring this back down so I can actually sit down now. Okay. See, I wasn't sure if that was going to work or not, but I think I did okay. All right, hang on, guys. I'm reconnecting everything because I had to put everything, disconnect everything to get that screen where I needed it to be. Give me just one moment. Okay. Yes? Okay. All right, guys, let me know. Were you guys able to get all of that? I need feedback. I need feedback from you guys because I really would like to start doing more demonstrations of exercises on the show. But as you can tell with the set, it's a little tough sometimes to be able to show you guys everything that I'm doing. So let me know if you guys heard everything, saw everything okay, if the angle of the camera needs to be better next time for you guys to see what's going on. Give me some feedback here. Ashley says, I haven't had the courage to go bigger than a tennis ball, but I still do the tennis ball a few times a week. And again, guys, a lot of the exercises I do with my patients, they're what I call bread and butter exercises. They're not like these high trendy fashion, super fancy technique and equipment exercises. These exercises have been around since like the 1960s and 70s. And the reason why we still have these exercises is because they work, especially if you take the time to do the form properly. And again, what I love about this exercise, what I love about the bridging exercise, it's another one of my favorites. I can give it to my beginner patients and then I can progress them as they get stronger up to my like high-end athletes. And we're talking about some of my athletes who are elite runners, and I have them doing a variation of this exercise. So for example, one of my elite runners, and you might be able to see that in the video that I posted. I just linked the video, and I'm going to link that video again. All right. So I put the link up there again, guys. The link to the YouTube video demonstrating the tennis ball exercises with one of my favorite patients, okay? So with her, the patient you're going to see in that video, she's incredibly high level. She whoops my butt on a regular basis and twice on Sunday on any of our runs, okay? So for her, I actually got the big Swiss balls, those big yoga balls, Swiss balls, exercise balls, whatever you want to call them, and I have her do the tennis ball exercise really fast on that. And believe me, she's hurting after she does that, okay? And again, if you're not able to do the tennis, if you're still working on the tennis ball, Ashley, one way you can actually challenge yourself more is by releasing one hand. So if you're nice and steady holding on with two hands, the next step would be to let go of one hand and then see if you can do it with no hands, right? So there's a lot of ways you can mix and match this exercise up to make it challenging, or if you're still a beginner, to kind of back up the intensity a little bit and make it work for you. Yes? All right, let me read some of these comments that came through. All right, good. You guys can hear me okay? Good. Ben Gregory, thank you for that feedback. Carolyn, this exercise benefits a lot of people. Most of my patients get some flavor form of this exercise and some flavor of the bridging exercise. Maybe next week we'll do the bridging exercise. What do y'all think? Thumbs up for me to demonstrate the bridging exercise and how to progress that? All right, Lonnie, thank you. Hey, Kay. Yes, I have shown this one, guys. I showed this one on my live event. Again, it's one of my favorite exercises for a good reason because it really works. And like I said, you're getting all that really great proprioceptive feedback because you're standing on your prosthetic leg. Your sound leg is up in the air. So you've got to put your body weight into that prosthetic leg. Okay, so it's a lot of really great feedback. Let's see, Brian says, I'm thinking of a large ball to get the back into prime shape. Just sometimes my natural movement is not enough. And again, Brian, if you're just starting with this exercise, don't get discouraged if you can't do that large ball right away. You might have to start with a smaller tennis ball. I'm a runner myself, and there are many times where I've slacked off on my strengthening and I got to go back to square one and use the smaller tennis ball. Joe says, I like working out with free weights, not necessarily the amount of weight you lift, but the control is what matters. And that's absolutely right. This, guys, I did a show in YouTube. Boy, I've done a lot of shows. There's a show on YouTube, on my YouTube channel, about the anatomy of muscle strengthening, like the anatomy and physiology, how a muscle is truly strengthened. And a lot of it has to do with using correct form so that you're targeting the correct muscle and then applying the correct amount of load. In order for a muscle to be strengthened, it has to be challenged. But a lot of times we think, oh, we need 500 pounds to challenge that muscle. No, you don't necessarily need to do 500 pounds. Sometimes just utilizing your own body weight in the right position. Good challenge right there. Good challenge right there. All right, David, I want to see you try that exercise, David, and let me know what you think. Ashley says, I do it with no hands already. I guess I need to quit being a baby about it. Yeah, girl, you too. Let's get the bigger ball. Let's get that soccer ball. And again, Ashley, when you start with the soccer ball, okay, put the 2 hands on it again. Okay, so when you go from the smaller ball, no hands, and you progress up to the next harder level, put your hands on it again until your body gets used to it. All right, let's see. Susan says, remember, I could only do stairs 1 foot at a time. Well, my hubby made a set of stairs that had half rise and I can walk up and down normally. Hallelujah. Once I master it, he will make new ones, but an inch higher and then an inch higher until I'm able to go up and down a standard rise. Susan, that is a wonderful accomplishment. I love hearing when you guys like get over these obstacles like this and you just keep trying and keep practicing. I love it. Love it, love it, love it. Thank you for sharing that, Susan. All right. Teresa's like, I like the cockroach one too. Yes, apparently I'm getting quite the reputation for being known as the 1, 2, 3 step cockroach PT. Not sure how I feel about that, but no, I'm kidding. It's fine. All right, guys, let's go to this next question here. This next question also came from Steve, and Steve had sent me a picture of his residual limb, and on the residual limb, there was a little about a quarter size patch of red skin. And again, it's kind of sometimes tough with a picture to see what's really going on because I like to be there in person. But the skin was red and it looked like it was dry. It looked calloused. Okay. And Steve was saying that, you know, because of his liner and his prosthesis and his socket, he just consistently was getting that red spot there. And it was on the trim line. So the edges of his socket. Okay. And he was asking, well, what do I do about this? Okay. So you guys hear me talk a lot about skin health. Okay. Especially for my brand new prosthetic users. Skin health is where it begins, guys. If your skin is not healthy, you're going to run into a lot of problems with your prosthesis. Okay. So then you have to also figure out chicken and egg scenario. You know, if you're having a red patch on your skin, is it because your skin's not healthy or because it's being irritated by the socket? So in this case, in the picture, it looked like a callus. Now, because this was the first time Steve was having a red patch of skin like that, I recommended that he go to his dermatologist. Why? Because the dermatologist can lay eyes on it in person and tell you, yes, that's a callus. No, it's not a callus. It could possibly be a little fungal infection. It could be a little bacterial infection. The thing is with these skin irritations and rashes, and we're going to have a big show on that on August 18th. Oh, get away from that. My cat's trying to drink my milk. On August 18th, we're going to cover all of that. But the big thing is to identify what it is you're looking at, because you're not going to treat a fungal rash the same way you treat a bacterial infection. And you're not going to treat any of that the way you would treat a callus. Okay. So let's just talk about the simple. I think it's a callus. Steve is going to do his due diligence and get it checked out by the dermatologist. So if the dermatologist says, yes, that in fact is a callus, then Steve's next step needs to be go back to his prosthetist and figure out what's going on with the socket. The only time a callus forms, guys, is when there's friction and shear forces. Something is irritating that part of the skin. You're either going to get a blister, a callus, or both, okay? And we don't want calluses. Here's why. Number one, it means that something's wrong with the socket. It's irritating your skin somehow. Number two, it's dry, cracked skin, okay? So that means bacteria can get in there and cause problems in the long run, okay? And we don't want that, especially when we have a lot of wonderful tools nowadays available to keep the skin nice and healthy. Capiche? All right, let's see. Susan says, Florida has the biggest cockroaches I've ever seen, the size of a mouse. Guys, she's not exaggerating. They are. They are the size of a small mouse, and they fly. They fly. All right. Hey, Karen, glad you could join us from California. Susan says, I have an invagination. When I sweat, it gets callous. So guys, an invagination, is when the scar on the skin starts to heal and basically it gets pulled in, right? So it's like you have a little crevice inside of your skin. And, there's a lot of people that get this. It's really hard if you don't get in there early to massage that scar tissue and start to mobilize that scar tissue. You can get some adhesions underneath the skin, and it can cause some of that invagination where the skin kind of folds in on itself. Okay. For the most part, with a lot of my folks, they can put their liners on and they don't have a problem. We just have to make sure that we keep that area nice and clean, okay, and moisturized properly and nice and clean and dry. Okay. So it's about, you got, if you're getting a callus on that area, Susan, it might be time just, again, go to the dermatologist and see what can be done to help with that callus. What can be done with your liner, for example? It might be that you might want to ask your prosthetist about getting a customized liner that can help provide some relief in that area. Okay. Also using the products. Again, I love using the Vital Fit products because they were made for people using prosthetic devices. So when I have someone who has a callus that we're trying to kind of work on, part of what I tell them to do is to moisturize that area, okay, to get it nice and soft again. Yeah. We're getting a lot of comments about the cockroach. All right. Guys, my comment section just went down. Can you guys just put in a couple comments just to kind of test it out for me, please? Can you guys just throw in the comment section, yep, you're still here. Just give me a thumbs up of some sort. As always, my internet likes to play jokes on me sometimes. All right, guys, I'm going to go ahead and go to the next question. If y'all can let me know if I'm still there. Okay. Here. Okay. You can hear me here. Okay. Thank you, guys. Thank you. Thank you. Okay. Next question. Oh, here was a nice hot topic question this week. One of the folks on one of the support groups. So guys, as I go through the week, I like to go through the support groups on Facebook and just see what are the common questions that I'm hearing. And oftentimes I'll just kind of put in the comment section, great question, I'll answer it on the show. And that way many people can benefit from the answers to the question. And also it gives me a chance to explain it fully. So this is a particular question. Thank you, guys. Thank you for letting me know. Hey, Stephen, better late than never. No worries, man. No worries. Stephen, actually, I just answered your question. So, Stephen, you're going to have to go back and listen to a little bit of the replay because I just answered both of your questions right now, buddy. Okay, so going on to this other question, and this is a question I do get a lot. Okay, this particular individual says, has anyone had a knee replacement on the sound side? I'm an above the knee amputee 20 years out, and I will need to do this the next year. So I'm curious about what you did to prepare. How was rehab? I'm very active in the gym and 5 days a week, and I'm worried about the downtime. I'm 60, so not a spring chicken anymore. I'll tell you what, guys, in PT years, 60 is still considered a spring chicken for me. For my 60-year-olds, I work them hard, okay? Guys, knee replacements and hip replacements, that is a very common thing that I do see in my amputee patients. It's a common thing I see in any of my patients over the age of 60. That's really one of the first things that you learn as a physical therapist, how to rehabilitate, is a knee or a hip replacement. Okay. The good news is knee and hip replacements are so common and the surgical techniques have become so advanced that surgeons can pretty much do them with their eyes closed, and PTs can go through those rehab protocols almost with their eyes closed as well. Okay. As an amputee, you're going to run into some of these problems, basically overuse injury. Okay. So when you have that amputation and you're first learning how to use your prosthesis, you're going to tend to favor your sound leg. That's why it's so important to get that early physical therapy in so that we can start getting that weight onto that prosthetic side as much as possible, strengthening everything like the glutes, like we did in that previous exercise, okay? And a lot of this is not only to make your gait nice and smooth and efficient, but it's to make sure that your sound side doesn't get abused. Okay, so you don't run into chronic injuries, so that you don't aggravate, for example, an arthritis that might be developing. Okay, but these things happen. These things happen, and it's something that I tell my folks this who are going in for a knee or a hip replacement. It's going to be easier to recover from your knee or hip replacement than it was recovering from your amputation. That's kind of my umbrella thing that I tell my amputee patients, because many of them are concerned. How are they going to be able to recover? Are they going to be able to walk again? And the answer is yes. If you get the appropriate rehabilitation, you will be able to recover your functional mobility that you had prior to that knee replacement. And in many cases, it might be better because with the new hip or the new knee, you're not going to be in as much pain anymore. Okay. Once the recovery process. Now, if you're as active as this particular individual, that's actually a really great thing because you'll have a head start. And if you have time before your surgery to get ready, then yes, you can get physical therapy, guys. Back when I was training as a PT 20 plus years ago, it was part of protocol that before you had an ACL repair, before you had a knee replacement or a hip replacement, you would go in for pre-physical therapy strengthening. This used to be part of our standard of care. Why? Because we would know that when the person is strong going into surgery, they're going to recuperate that much faster after surgery. Unfortunately, nowadays, insurance doesn't want to pay for that, but it doesn't mean that you shouldn't try, okay? And if you're able to pay for 1 or 2 sessions of physical therapy prior to your surgery, highly, highly encourage it, okay? And the big bulk of this is, so all right, so you've had your surgery, you've had your replacement surgery. How many of you guys, let me hear. How many of you guys here have some sort of joint replacement, whether it's on your amputated side or on your sound side? How many of you have some sort of joint replacement? Let's take the Cosi poll and put it into the comments section. So Susan says, I broke my hip on my prosthetic side and had hip replacement. And guys, that sometimes happens too, because on the prosthetic side, you sometimes start to lose bone density over the years, right? So it's going to be a little bit more prone to a hip fracture or a knee fracture, right? Susan says me. Carolyn says me. Leanne says, oh, hey, Leanne, so glad you can make it. Brian says replacement hip on the sound side. Hey, Patrick, glad you could join us. There's my other PT, and I know he'll be able to chime in on this as well. We're talking about hip replacements, Patrick, and knee replacements. So Carolyn says she's had replacements on her femur and her knee. David says, I have a knee replacement, and a hip on the sound side. So he's had both joints replaced. And I just listen carefully to what my body is saying. Linda says, hip replacement on the meat side. Hey, Patrick, I try. And Brett says, before the accident, he had a replacement on his side as well. Okay, so guys, when it comes to the replacement protocol, hip and knee replacement, it's 3 basic things. Get up and get moving as soon as you can after your surgery with the help of the physical therapist. Get the mobility, the movement back in that particular joint, especially if you've had a knee replacement. You need to get that knee moving a certain amount of degrees, usually before you're discharged home. Usually the standard protocol, and Patrick helped correct me on this, is 90 degrees. Usually most surgeons want to see that you can bend your knee at least 90 degrees and straighten it out all the way before you're even sent home. And again, this is all done with the help of the physical therapist. And then third on that list, and certainly not least, is the strengthening. Okay, a lot of generalized strengthening around the muscles of that particular joint. And again, those of you who went through an amputation, you've already done this. You've already done much of the strengthening protocol, or you should have anyways, with the physical therapist. So recovering from a hip or a knee replacement will be very similar in that regard. A lot of strengthening, a lot of movement in the particular joint, and then getting up and walking, okay? Jody asks, what do I think about traveling on a bus across the country this time of year with a prosthetic that is too big, not vaccinated, and sitting for 3 days and gets blisters with this heat and COVID? Not a good idea. No, I'm thinking that's not a good idea, Jody. If you're traveling, and I recently just came back from a trip myself. When you're traveling, you need everything to fit properly. Definitely everything to fit properly. And if you're going to be sitting for 3 days on a bus, you're not going to have a lot of movement if your socket's not fitting properly. I think you're kind of setting yourself up there, Jody. So I would say get yourself to your prosthetist and make sure that that leg is fitting properly before you take any kind of a trip. That's just a basic safety measure right there. And just comfort. You don't want to be uncomfortable on your trip with a lousy fitting socket. So if your socket needs adjustments, definitely get that done before you travel. Definitely. Oh, thanks, Ben Gregory. My pleasure. Let's see. So Patrick, my other physical therapist up in New York, he says we want 90 degrees by 2 weeks or so, follow up 120 degrees flexion with the outpatient. Okay, so where's Bob? See, now I know my kids have been in this room because I can't find Bob. That means they've been playing with Bob. All right, guys. So basically, if this is your thigh and this is your lower leg, if you're having a knee replacement done, 90 degrees is about here, 120 degrees is about bending that much. Okay. So that's usually in for the knee. The hip mobility and the movement in the hip usually comes back pretty easily. Usually it's about making sure that you can extend your hip. But again, since you've been through amputation surgery, that's something that you've already had to deal with before. Okay. Let's see. Andrea says hip replacement on the amputated side can be tough. Yes, if you have hip precautions, it can be tough, but it is possible. Usually, it's what I say, guys. It's the first 4 to 6 weeks. Those are usually the toughest weeks when it comes to these replacement surgeries. With the hip replacement, sometimes it's called hip precautions, guys. And basically, what that means is that you can't move your hip in a certain direction during those first few weeks, just to make sure it's healing properly and that it doesn't dislocate. And again, this is something that your therapists drill into, your PT, your OT, your nurse. People drill this into you so you have this well ingrained in your head before you go home. Okay. And yes, getting up standing on a hip, a replacement hip on your prosthetic side can be challenging. But this is where the physical therapist comes into play. This is where getting into a set of parallel bars, guys. This is where parallel bars are just the most powerful tool in physical therapy sometimes, because you can hold yourself up and start gradually weight bearing into that side. Okay. And again, guys, if this is something that you're going into, and usually for your joint replacements, you're going to have a joint replacement. It's not usually an emergency unless you've had a fracture. Okay. If you know that you're going to have a joint replacement, it behooves you to try to get that physical therapy in before. Okay. There's a lot that the therapist can do to help strengthen those muscles and get them really nice and prepped for surgery. And also, there's a lot that the therapist can help you learn about mobility and kind of working with you and saying, okay, this is how, if you're having the replacement on your prosthetic side, okay, this is how you walk using just your one sound side with the walker, and just kind of prepping you for some of the mobility that you might have to do after surgery. Make sense? Okay. There you go. Patrick's busting up all the protocols there. I love it. Yeah, so Susan said she had restrictions for hip precautions for 3 months, and it's tough. It is tough, especially when you're trying to get up from a chair and you're not able to bend forward. That's usually one of those hip precautions. And again, guys, I worked, several years in ICU and inpatient and inpatient rehab care in the hospitals, but I also did several years working in home health, where I would get folks after they came home and having to modify their home, having to modify the chairs that they would sit in, to make sure that they were following these hip precautions, right? So again, advocate for yourself. If y'all are sensing a theme here from me tonight, it's advocate for yourself, get that physical therapist, get the occupational therapist throughout the entire process of recovery. Yeah, you spy Bob behind a tree, Ashley. That's my full size Bob. He's like literally, that Bob is like almost 6 feet tall. He's huge and he doesn't bend very well, so it's kind of hard to use him as my model. He's not quite as bendy. All right. Yes, so total knee replacement. When you're doing a total knee replacement, the full extension of the knee. That's the other big thing that we work on. Hey, Harsh, how are you? Yes, I will say that. And Patrick is absolutely right. When it comes to these replacement guys, a lot of people are really, they're scared because it's a big surgery, right? But what they don't realize is they're going to have a huge relief from pain. Okay. A surgeon is not going to want to replace one of your joints unless that joint looks like Swiss cheese. I mean, honestly, the arthritis, basically, that's the point when a surgeon will replace a joint, is when that joint is so degraded and it's causing so much pain that the person simply cannot function anymore in their daily life. That's basically when they say, okay, now it warrants having a big surgery. So once people have surgery, yes, they're in pain from the surgery itself, but it's a different kind of pain. I call it the healing pain. So it's a different kind of pain, and people are usually surprised at how much less that pain is compared to the pain they had prior to surgery. Guys, feel free to chime in on this one, okay? A lot of times people are so scared to get these replacements done, but then when they have them done, they realize, wait a second, I don't have that much pain anymore. There's not that pain anymore after they finish recovering. So Yes, and definitely, as all protocols with physical therapy, it takes time, guys. And then Patrick is right. How do you eat an elephant? One bite at a time. So you have to take these protocols. And like I said, I tell folks the first 4 to 6 weeks, those are the toughest ones. And you just got to get through those. And then you'll start to see a noticeable improvement in quality of life and mobility. All right. Patrick, you are on fire tonight. Love it. Love it. Patrick, you're going to have to do a show with me at some point. All right. So here's another one. Ooh, I always like this question because I'm a huge fan of these. This particular person asked, how soon after surgery did you have your shrinker sock put on? Okay. And I'm actually, bear with me for a second, guys. I'm going to throw another video up there because I think this is an important one. Guys, here we go. All right. I am throwing this video up there. Stay with me. Stay with me. Stay with me. Okay. So here's another video from my YouTube channel. And in this one, I talk about limb shrinkage and volume changes. It's under my 2-minute chat. Okay. And guys, if you check out that video, underneath that video, I have links to other information about that. All right. So guys, when it comes to wearing a shrinker, okay, you're out of surgery, you've got this massive residual limb that's full of swelling and inflammation and pain, right? And then in comes the prosthetist or the physical therapist or the surgeon, and they say, here, put this compression sock on that's going to make it really tight and snug. And you're sitting there going, are you crazy? I'm in pain. Okay. There is a method to this madness, guys. This compression garment, it looks like a tube sock, okay? It's called a shrinker, okay? And it's meant to help do exactly that. It's meant to help shrink that residual limb down. It's helping with the compression that it's providing, okay? In compressing your limb, it's helping push that inflammation out. And when you get the inflammation out, your pain starts to go down, okay? And it also starts to help remodel and shape the residual limb in order for it to fit nicely into a prosthetic socket. Okay. So guys, if you want to learn more information about that, go ahead and listen to the video I just posted over there on my YouTube channel. Okay. But basically, the sooner that shrinker can go on, the better. Okay. Now, every surgeon's a little different with their protocol. Some surgeons are just like, don't touch my surgical site. Don't touch that wound. Leave it alone. Don't do anything to it. And you're sitting there going, okay, you got to wait till it closes and then the surgeon lets you put it on. But for the most part, surgeons are pretty good eggs and they want to put that shrinker on carefully without, disrupting that surgical site to start getting that good compression in. Andrea, if you're still on board, can you tell me when your surgeons in your hospital like to put the shrinkers on their patients? Can you put that in the comment section for me? And any of you, those of you who used shrinkers, which hopefully all of you did, at what point did your surgeon or your prosthetist put that shrinker on your residual limb? Put that one in the comment section for me, guys. I'd love to know. Okay. And guys, with the shrinker, this is not a lifelong thing. This stays on you, okay, 23 out of 24 hours a day. Okay. The 1 hour a day you get to take it off is when you're doing your hygiene, but then you need to put it right back on because the minute you take your shrinker off, the leg is going to want to swell up and do a rebound swelling again. Okay. So once again, you put it on for most of the day. When you start wearing your prosthesis, you don't put it on with the prosthesis, by the way. Let me clarify that point right there. You don't want to put it on with the prosthesis, okay? But the minute you take your prosthesis off, shrinker should go back on. And you do this until you notice that your residual limb has plateaued in shape, meaning it's not bubbling up or going down anymore, that it is the same shape and it stays consistent. And that you can take anywhere between 1 to 2 years, depending on the individual. Sounds good? Yeah. Let's see. Okay, sorry, I'm trying to read through some of these comments, guys, that have come in. Hey, Rita, glad you could join us. Debbie says they put on her shrinker right away. And how long should someone wear it? I think 6 months, a year. And again, Debbie, it's when the residual limb starts to plateau in shape. Some people by the 1 year mark, they've got that final residual limb shape. Other people, they're still shrinking, okay? Or they're going up and down. People who have other underlying medical conditions, blood pressure, diabetes, autoimmune diseases, kidney disease, their limb is going to change shape for the rest of their life. It's going to be bigger some days, smaller the next. So using the shrinker at nighttime is really great because it helps keep it more consistent through the nighttime when the prosthesis is off. Okay. And the other thing I tell folks is make sure you update your shrinker. Okay. If you can pull your shrinker on and you haven't broken a sweat, that means it's too loose. Okay. The shrinker needs to fit kind of like a Spanx garment, those compression garments that ladies wear to make them look nice and svelte. Okay. So it needs to take a little bit of effort to put it on. You don't want to hurt your surgical site and you don't want to be too rough, but it needs to be snug in order for that compression to take effect. Okay. Now, in some places, they might actually use a special technique of wrapping Ace bandages, and that goes in a very particular crisscross format. And that's actually something that's way back old school, but some folks still use that technique, and it's still a very valuable technique. Okay. Susan says, I used the Ace bandage until my stitches healed and then went to a shrinker. So, for example, some surgeons prefer the Ace wrap because obviously you're going around the residual limb and you're not pulling up on that surgical site. So some people might opt to use that Ace wrap instead, but it has to be put on a very specific way. Let me make that caveat. The Ace bandage is not just going around like this, like a mummy. Okay, not a tourniquet effect. It's a very specialized figure 8 pattern going up the leg. And again, the whole point of that is to help create compression, a graded compression to get that fluid up and out of that residual limb. So Sandra got hers at the 4-week mark. Andrea says month out or after the stitches are out. Ashley says 5 weeks post-op, surgeon would not let me have shrinker until he looked at the stitches and staples out. But my prosthetist was at that appointment and fitted me for a shrinker that day. Okay, so again, guys, this is where sometimes, surgeons are a little bit different. David says he got his 2 days after surgery. Ben Gregory says, oh, better tell him that first shrinker puts on hurts like all get out, and that's putting it nicely. I believe you, Ben Gregory. Within a week, still wearing them 4 months later and see a tremendous difference in surgery. And yes, definitely, guys, you put any kind of anything on any freshly amputated limb, it's going to hurt. Okay. But there's a difference between ow, 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 that hurts versus, oh my God, I'm seeing stars and I'm going to pass out from the pain. If it's the, oh my God, I'm seeing stars and I'm going to pass out from the pain, it could be that shrinker is too tight. Okay. Again, it needs to be compressing, but it doesn't need to be squeezing and strangling that poor residual limb. Okay. And again, the compression garment, the kind that you put on, the shrinker, that kind, if you're putting it on after the stitches are gone, okay, and after that surgical site is healed, it's going to take a little bit of effort, but you should be able to put it back on. Okay. So Andrea, my OT, says I prefer no drainage, and if we can get a bandage on that confirms well. That conforms well. Yes. And again, guys, the first goal is to protect that surgical site. Okay. So again, some surgeons might have you wait until the surgical site is completely closed and the stitches are out. Some surgeons, perhaps like the one David had, they prefer to have it early on, but they might do something like an Ace wrap to, again, protect that surgical site. Others might say, yes, let's do a shrinker, but let's make sure we have a dressing over it. And guy, I used to remember when, if I was putting a shrinker onto a fresh amputated limb, meaning the surgical site was still, the stitches were still there, we would put a protective dressing over it, and then I would carefully roll the shrinker up on the leg so I'm not pulling and not shearing on that surgical site. So again, lots of TLC there. So Ashley says, I will be 4 years post-op in November and I still wear a shrinker if I do not have my leg on. Let's see. Okay. Figure 8 pad. Okay. Sorry. Yes. And Andrea is absolutely right. The Ace wrap technique that I was talking about, guys, if it is not done properly, it can do major harm. And again, this was a figure 8 technique that it was in. This cat keeps trying to get to my milk. It's hilarious. She keeps trying to get to it. Okay, so when I was in school, when dinosaurs roamed the earth, we didn't have shrinkers. We had to do the Ace wrap technique. And my instructor, he made me do it at least 7 times before he was satisfied with how I did it. It's a very precise wrapping technique, and it goes in a very specific way. if it's not done properly, you are going to cause a lot of damage. So again, guys, if you're doing an ACE wrapping technique, this is something that has to be taught to you by the nurse, by the physical therapist, by someone who does that specialized figure 8 technique. If you just wrap it around your limb like that, you're creating a tourniquet, and that can cause a lot of problems down the line. Okay. Linda says it's been 5 years in July and I still wear my shrinker if I'm not wearing my leg. Rita says, how often can you get a new shrinker? That's a good question, Rita. I know that sometimes with some of my patients, the prosthetist, as the person was shrinking, if the shrinker was still in good shape, like it still had a lot of good elasticity to it, the prosthetist would kind of pinch off and put a seam in it to kind of make it smaller, to get a little bit more life out of that shrinker. But I would imagine, like any medical device, if it's something that is medically necessary and you've outgrown or it's become too large for you, then your insurance should be able to pay for another one. Let's see. 2.5 years after amputation, I still use my shrinker. This is David, and I like the way it makes my residual limb feel at night. I've heard that a lot from my patients as well, especially my patients who have a lot of soft tissue at the end of their residual limb. They like that compression at night because they feel like it's not kind of, the soft tissue isn't wiggling around in the bed quite as much. Linda says she got her shrinker after the staples came out. Conical shape is the goal. Yes, a nice conical shape is the nice goal for the residual limb. And that's the other part of the shrinker, is not only just to shrink it, but also to help shape it. Above the knees have the option of the open-ended sprinkler. Help me out, Andrea. I don't think I've ever heard the sprinkler, which can be a good place to start. Help me out. So Susan says, I was a pro at using the Ace bandage. It did it as well as the PT. Yep. And again, guys, this is on the couple of occasions I've had to teach my patients. I'm about as hard strict as my instructor was on me. And many times my patients end up doing a much better job than I do because they get just that much more practice on their own limb. Ben Gregory says, I massage my stumps with the shrinkers on. It helps relieve the phantom pain sensation and aids in molding them for shaping. And that's another thing I've heard, guys, that folks, when they're having some of these phantom limbs and pain and sensation, when they put compression on with the shrinker, it kind of helps sometimes with that. Rita says hers is really worn out. Time to get a new one, Rita. And guys, this is another thing I always like to recommend, especially now in summertime where folks are kind of trapped. Well, maybe not as much right now, but eventually when folks start traveling, is I tell people, take their shrinker on the plane. Okay. As you go up in a plane with the pressure changes, your limb can increase or decrease in shape. So if you're thinking of taking your prosthesis off while you're on the plane, just because you got a little more room there, okay, put the shrinker on to make sure that it's not going to blow up on you in the plane. If you keep your prosthesis on during the entire flight, still take your shrinker with you, because when you get to the hotel or your destination or wherever you're going, I know my ankles are always really puffy after any kind of a flight. And for you, you might get some of that rebound swelling after you come off the plane. So it's always good to have that shrinker with you just in case. Okay, thank you, Andrea. I'm sorry. Thank you. I wasn't sure what you were saying. Thank you for clarifying that, Andrea. Yeah, she autocorrected. I got it, guys. Thank you. Thank you. All right, guys. I think I've addressed all the questions that came in this week. Guys, I'm really trying to kind of work things up with the YouTube channel and also with my Instagram account. If you're not already following me on Instagram, if you wouldn't mind heading over there and following me on Instagram, and also with my YouTube channel, I'll put a post. If you wouldn't mind subscribing to my YouTube channel, guys, the more we grow this platform, the more we can get this information out there to different folks. So that is my shameless plug for the evening. Guys, if I missed your question, please, you can email me through my website. You can email me on Facebook. You can find me pretty much everywhere. It's kind of hard to miss me. It's all under Cosi Talks. Be sure you send your questions in to me. Next week, it'll be another general Q&A, so get those questions in. Guys, mark your calendars, because later on this month, on August 18th, I'm going to have a dermatologist right here in the Cosi Talks house, and we're going to be talking all about rashes and all that kind of stuff that pops up on your skin and how to manage it. And then later, at the end of this month, I'm so excited about this, I am teaming up with Amplitude Magazine, and we are going to be talking Paralympics because we've got some former Cosi Talks guests who are in their first Paralympics this year, and I'm so excited to see them kick butt and take names for the US of A. So the last 2 weeks, the last week of August, first week of September, we're going to be talking about the Paralympics, about the history, lots of good stuff we're going to be doing. So definitely put that in your calendar, guys. It's going to be a lot of fun. All right, guys, as always, thank you for letting me be a part of your lives this evening. If I didn't get your question, send a message to me and we will get to it. All right, I'll see you guys next week. Same bat time, same bat channel.